Welcome back to the Deep Dive, where we take your source material and, well, really unearth those crucial nuggets of knowledge, making even the densest topics crystal clear. Today, we're embarking on a pretty ambitious journey, right into the heart of the human brain.
Indeed.
Our mission, to go deep. We're talking about achieving a level of mastery over this information, like true professionals in the field. Really dissecting every concept and connection until it's second nature.
That's the plan.
We've got some fascinating material in front of us today, drawn from a comprehensive neuroanatomy text to guide our exploration.
And that's precisely what we'll do. This deep dive will offer you a thorough, really precise understanding of the cerebrum. We'll start with its central structures, the very core, and then branch out to its larger, more familiar hemispheres.
Okay.
We'll clarify the intricate relationships between these complex parts and explore their vital roles in, well, everything from sensation and movement to emotion and basic bodily functions.
So not just naming parts, but understanding the whole architecture.
Our goal is exactly that, to truly understand the architecture.
Absolutely. And to kick us off, let's unpack a captivating real-world scenario from our source that I think instantly highlights why this deep understanding is so critical.
Okay.
Imagine a 23-year-old man. He's experiencing intermittent headaches, dizziness, and this puzzling weakness and numbness in his left leg.
Right.
Here's where it gets really interesting. His headaches are made worse simply by changing his head position.
Oh, wow.
A CT scan then reveals a small, unexpected, white opaque ball right at the anterior end of his third ventricle. The diagnosis: a Colloid cyst.
Yeah, the striking thing about this case is how that seemingly simple act, just moving his head, exacerbates the symptoms.
Right.
This mobile cyst, which was suspended from the choroid plexus, literally acts like a ball valve.
Like a little plug.
Exactly. When he changes position, it temporarily blocks the foramen of Monroe. That's an opening on the right side.
Okay.
And this blockage then leads to a rapid increase in pressure inside his skull, what we call increased intracerebral pressure and hydrocephalus.
So the pressure explains the headaches and dizziness.
Makes sense, yeah.
But what about the weakness and numbness in his left leg? That seems less direct.
That's the key to understanding the precise anatomy here. That slowly expanding tumor, the cyst, it was pressing on the right thalamus.
Ah, the right side.
And the nerve tracks within the right internal capsule. So right-sided pressure affects the left side of the body.
Got it.
This case perfectly illustrates the critical anatomical relationships we're about to explore. The good news is he made a complete recovery after surgery.
That's great.
Which is a powerful demonstration of why understanding these structures and their precise locations is so vital for diagnosis and treatment.
That's an incredible story to start with. Really shows just how interconnected and, frankly, sensitive our brains truly are. Okay, let's zoom out then and start with the big picture. The cerebrum itself.
Right, the cerebrum. It develops from what's called the telencephalon, that's essentially the embryonic forebrain, and it constitutes the largest, most recognizable part of the adult brain. Each half, or hemisphere, is composed of an outer layer of gray matter we know as the cortex.
The wrinkly bit.
The wrinkly bit, exactly. Then there are internal masses of gray matter called the basal nuclei and a fluid-filled space inside, a lateral ventricle.
So what's the overall organizational principle at play here? How is it structured?
Well, the cerebrum, as the largest structure, it fills the entire upper part of the skull. For clarity, for our understanding, it's divided into two main parts.
Okay.
There's the diencephalon, which forms its deep central core.
The bit we just talked about with the cyst.
Exactly. That opening clinical case was a perfect example of pathology right there in the diencephalon. And then there's the telencephalon, which forms the familiar, much larger cerebral hemispheres that surround that core.
That's a great way to frame it. Okay, let's dive deeper into that central core then, the diencephalon. What exactly defines this crucial region?
You can define the diencephalon quite precisely. It encompasses the third ventricle, that fluid space, and all the structures that form its boundaries. It extends backward to where the third ventricle connects with the cerebral aqueduct and forward as far as the interventricular foramina.
The openings to the other ventricles.
Right. And it's important to grasp that it's a midline structure, meaning it has symmetrical right and left halves. It really acts as a central hub.
When we look at an intact brain, or maybe specific cross-sections, what parts of this central core are actually visible and what's hidden away?
Good question. Only its inferior surface, the bottom, is openly visible in an intact brain.
Okay.
This includes, from front to back, the optic chiasma with its optic tracts where some visual nerves cross,
Right.
the infundibulum with the tuber cinerarium and the mammillary bodies. Its superior surface, however, the top, is largely tucked away.
Hidden.
Concealed by the fornix, that's a thick bundle of fibers originating from the temporal lobe's hippocampus that arches posteriorly over the thalamus to connect with the mammillary bodies.
Okay, so the fornix covers it. And what actually forms the superior wall itself, the roof of the third ventricle?
That's formed by a layer of ependyma, which is a specialized lining you find throughout the brain's fluid-filled spaces.
Right.
Superior to this ependymal layer is a vascular membrane called the telechoroidea of the third ventricle.
Vascular meaning blood vessels.
It's not exactly a delicate blood vessel-rich membrane. And from this membrane, the choroid plexuses, the structures that actually produce cerebrospinal fluid, project downwards into the ventricle cavity.
So if that's the roof and the inferior surface, what about its side boundaries? Where does the diencephalon meet the rest of the brain laterally?
Its lateral surface is bounded by the internal capsule.
That structure again from the cyst case.
The very same. A critical band of white matter packed with nerve fibers connecting the cerebral cortex with the brainstem and spinal cord.
Okay.
Its medial surface, on the other hand, forms the lateral wall of the third ventricle itself. Here, you'll find the thalamus superiorly and the hypothalamus inferiorly, neatly separated by a groove called the hypothalamic sulcus. And there's a ridge, the stria medullaris thalami, which carries fibers to the habenular nucleus, running along its superior medial margin.
So the diencephalon isn't just one big blob. It's broken down into, what, 4 distinct yet interconnected main parts, right?
Exactly. Those 4 parts are the thalamus, the subthalamus, the epithalamus, and the hypothalamus. Each plays a distinct and absolutely vital role.
Let's start with the thalamus then. It's a term many people might recognize, often called the brain's grand central station. What makes it such a critical component?
It's a pretty apt analogy, actually. The thalamus is a large, sort of egg-shaped mass of gray matter, making up the largest portion of the diencephalon.
Okay.
Its immense functional importance stems from its role as a crucial relay station for nearly all the main sensory systems.
All of them.
Pretty much every sight, sound, touch you experience, with the sole exception of the olfactory pathway, smell.
Smell bypasses it.
Smell bypasses it, yeah. But everything else first passes through the thalamus. Its activity is deeply intertwined with the cerebral cortex, so damage here can cause significant, widespread loss of cerebral function.
Knowing its critical role, where precisely is it located within this complex landscape?
It sits on each side of the third ventricle. Its narrow, rounded anterior end forms the back boundary of that interventricular foramen, the opening to the lateral ventricles.
Right.
The posterior end expands into what's known as the pulvinar, which actually overhangs a part of the midbrain called the superior colliculus. And you'll also find a small bump on the underside of the lateral pulvinar, which is the lateral geniculate body, involved in visual processing.
In its various surfaces, what do they tell us about its connections? How does it interface with everything else?
Well, the superior surface is medially covered by that delicate telechoroidea and the fornix we just discussed. While its lateral part is partially hidden by the choroid plexus of the lateral ventricle, inferiorly it blends seamlessly with the tegmentum of the midbrain. The medial surface forms the upper part of the lateral wall of the third ventricle and is quite often connected to the thalamus on the opposite side by a band of gray matter called the interthalamic connection or adhesion.
A little bridge between the two halves.
Kind of like a bridge, yeah, though not everyone has it, or it varies in size.
And its lateral boundary. What's separating it from other major structures on that side?
The lateral surface. It's separated from the lentiform nucleus by this exceptionally important band of white matter we mentioned earlier, the internal capsule.
Right, the fiber highway.
Exactly. This is a critical anatomical relationship because of the sheer volume of fibers packed into that internal capsule.
So if it's a cell station and a relay hub, what kind of information is it specifically processing before sending it on? Is it just passing messages?
Not just passing them along, no. It receives input from numerous afferent or incoming sensory tracts, but it integrates and filters a lot of that information.
Sorts it out.
Sorts it out, yeah. Then it relays it, meaning it sends efferent or outgoing signals to the cerebral cortex for conscious perception and to various other subcortical regions. It also plays a key, if less obvious, role in integrating visceral, internal, organ, and somatic body functions.
That makes me wonder then, what happens if the thalamus is damaged, especially given its role as this central sensory hub.
Yeah, thalamic lesions are often caused by issues with its blood supply, like a thrombosis, a clot, or a hemorrhage, a bleed in one of its supplying arteries.
Okay.
Because the thalamus receives sensory impulses primarily from the opposite side of the body.
Right, the contralateral side.
Any disability will predictably be confined to that contralateral side. This can lead to profound impairment of all forms of sensation, everything from light touch and tactile localization to discrimination between 2 points, and even the loss of awareness of joint movements. It truly shows how central it is to our perception of the world around us.
Wow, that's a powerful demonstration of its impact. Let's move on to the next part of the diencephalon, the subthalamus. Where is it situated and what's its claim to fame?
The subthalamus. It lies just below the thalamus, kind of tucked between the thalamus and the midbrain's tegmentum. It's also connected toward the front and middle with the hypothalamus.
What critical structures are packed inside this somewhat compact region?
It contains important collections of nerve cells, notably the upper parts or cranial ends of the red nuclei and the substantia nigra areas involved in motor control.
Okay.
The subthalamic nucleus itself is shaped like a biconvex lens and has vital connections with the corpus striatum.
Another structure involved in movement.
Exactly. As a direct consequence, the subthalamus is heavily involved in the precise control of muscle activity. It also serves as a conduit for many crucial tracts traveling upwards from the tegmentum to the thalamic nuclei, like the medial, spinal, and trigeminal lemnisci major sensory pathways.
We actually saw a very dramatic clinical case related to this earlier in our sources, didn't we? The woman with the uncontrolled movements.
We did. That 53-year-old woman who came into the emergency department exhibiting those violent, uncontrolled movements of her right arm and leg, with even slight spontaneous movements on the right side of her face.
Yeah.
That condition is medically known as hemibolismus, and it was caused by a hemorrhage directly into the left subthalamic nucleus.
Left side causing right side symptoms again.
Always that contralateral control. This clinical example truly underscores its critical, precise role in regulating and coordinating muscle activity. Losing control of such a small structure can have profound, widespread motor effects.
That's incredibly insightful. So what about the epithalamus? What are its main components?
The epithalamus consists of 2 primary parts, the habenular nuclei and their connections, and the pineal gland.
Okay, tell us about the habenular nucleus first. What's its function, or at least what's it believed to be?
It's a small group of neurons nestled just medial to the posterior surface of the thalamus. It receives incoming fibers, afferent fibers, from the amygdaloid nucleus in the temporal lobe via the stria medullaris thalami, and other fibers from the hippocampal formation through the fornix. Some of these fibers even cross the midline, forming the habenular commissure to reach the habenular nucleus on the opposite side.
Okay, so it gets input from emotional and memory centers.
That's right. Its axons then project to areas like the intrapeduncular nucleus, midbrain tectum, thalamus, and the reticular formation of the midbrain. While it's complex, it's believed to be a central point for integrating olfactory smell, visceral, internal organ, and somatic body sensation pathways, sort of a sensory integration spot.
And the pineal gland, also known as the pineal body. Many people might have heard of this one, sometimes with a touch of mystery surrounding it.
Indeed, it often pops up in popular discussion. The pineal gland is a small, cone-shaped structure attached to the diencephalon by a pineal stalk. It projects backward to lie just behind the midbrain.
Okay.
The base of the stalk has a recess that's continuous with the third ventricle cavity. The superior part of the stalk's base contains that habenular commissure we just mentioned, and the inferior part contains the posterior commissure.
And if we were to look at it under a microscope, what would we see? What's it made of?
Microscopically, it's incompletely divided into small lobules by connective tissue septa. It contains 2 main cell types. Pinealocytes, which are the primary functional cells.
And one's doing the work.
The ones doing the work, yes. And glial cells, which are the brain's supportive cells. As we age, something interesting happens. Concretions of calcified material, often called brain sand, progressively accumulate within the gland.
Brain sand. That actually sounds familiar from our clinical notes. Is it actually important or just a biological curiosity?
It is surprisingly important. While the pineal gland itself doesn't contain its own nerve cells, it's supplied by adrenergic sympathetic fibers from the superior cervical sympathetic ganglia. Those calcified deposits are incredibly useful to radiologists.
How so?
They serve as a crucial midline landmark in X-rays or CT scans. They help determine if a space-occupying lesion, like a tumor within the skull, has displaced the brain laterally, pushed it to one side.
Yeah.
That 64-year-old man we saw in the clinical problem section, for instance, his X-ray showed a pineal gland shadow precisely in the midline. That helped confirm that no large cerebral tumor was present and pushing things around.
So it's more than just a landmark. What about its actual function? For a long time, it was thought to be pretty insignificant, right?
That perspective has changed dramatically. The pineal gland is now recognized as an important endocrine gland.
Endocrine, meaning it releases hormones.
Exactly. It deeply influences the activities of many other glands. The pituitary, the islets of Langerhans and the pancreas, the parathyroids, the adrenal cortex and medulla, and the gonads.
Wow, quite a reach.
Its secretions, produced by the pinealocytes, reach target organs via the bloodstream or the cerebrospinal fluid, and their actions are mainly inhibitory.
Inhibitory, so they slow things down or turn things off.
Generally, yes. This can be through direct inhibition of hormone production or indirect inhibition of releasing factors by the hypothalamus.
Yeah.
And here's a fascinating detail. The pineal gland does not possess a blood-brain barrier.
Really? That's unusual.
It is. It allows it direct access to circulating substances in the blood and allows its hormones easy access out.
That truly is surprising. And how does it relate to our daily rhythms, our sleep-wake cycle?
Animal experiments have clearly shown its activity exhibits a circadian rhythm profoundly influenced by light.
So light is the trigger.
Light is the main regulator. It's most active during darkness. The probable nervous pathway involves signals starting in the retina, projecting to the suprachiasmatic nucleus of the hypothalamus, the brain's master clock,
Okay.
then to the midbrain tegmentum, and eventually via the reticulospinal tract, sympathetic outflow, and the superior cervical sympathetic ganglion to the pineal gland itself. It's a clear pathway. Light influences brain chemistry and body function.
And what's the key hormone involved in this regulation, the one people might have heard of?
Melatonin. High concentrations of melatonin and the enzymes needed to make it are found right there in the pineal gland. It's released into the blood or the CSF of the third ventricle. From there, it travels to the anterior lobe of the pituitary gland and inhibits the release of gonadotrophic hormone, which influences reproductive function.
So it affects reproduction too?
Yes. In humans, just like in animals, plasma melatonin levels rise in darkness and fall during the day. This strongly indicates its important role in regulating reproductive function. Clinical observations of patients with pineal tumors or pressure on the gland often show severe alterations of reproductive function, further solidifying this link.
Fascinating stuff. Okay, now for the hypothalamus, another incredibly important part of the diencephalon, despite its relatively small size. What makes it so mighty?
The hypothalamus. It's that part of the diencephalon extending from the optic chiasma region back to the caudal border of the mammillary bodies. It lies below the hypothalamic sulcus on the lateral wall of the third ventricle.
Small but powerful.
Anatomically small, yes, but strategically placed. It has close connections to the limbic system, the thalamus, ascending and descending tracts, and the hypophysis or pituitary gland. Microscopically, it's composed of small nerve cells arranged in distinct groups or nuclei.
So what's the practical upshot of this strategic placement for its overall function? What does it do?
Physiologically, you could almost say nearly every activity in the body is influenced by the hypothalamus. It's the master controller and integrator of the autonomic nervous system, our involuntary function.
Like breathing, heart rate.
Exactly. And the endocrine systems via the pituitary. This makes it absolutely vital for maintaining body homeostasis.
That internal balance.
That crucial internal balance. This includes regulating body temperature, body fluids, our fundamental drives to eat and drink, sexual behavior, and emotion. It also plays a key role in orchestrating the release of hormones from the pituitary gland. It's a major control center.
Given its central role, how does it relate to the structures immediately surrounding it? What are its neighbors?
Okay, its neighbors. Anteriorly, it's connected to the preoptic area, extending forward from the optic chiasma to the lamina terminalis and anterior commissure. Caudally, it seamlessly merges into the tegmentum of the midbrain.
Right.
The thalamus lies directly superior to it, and the subthalamic region lies inferolaterally.
And what structures can we actually see if we observe it from directly below, looking up at the base of the brain?
From below, looking from anterior to posterior, you'd observe the optic chiasma first,
Right.
followed by the tubercinarium and the infundibulum, and finally the mammillary bodies. Those are the key landmarks you'd identify on the inferior surface.
Let's unpack those three structures then, starting with the optic chiasma. Why is it such a crucial landmark? We mentioned the visual crossing earlier.
Right. The optic chiasma is a flattened bundle of nerve fibers at the precise junction of the third ventricle's anterior wall and floor. Its superior surface is attached to the lamina terminalis. Inferiorly, it relates to the hypophysis cerebri, the pituitary, separated by the diaphragma sellae. Crucially, its anterolateral corners are continuous with the optic nerves coming from the eyes, and its posterolateral corners with the optic tracts going deeper into the brain. A small optic recess of the third ventricle lies on its superior surface.
And the crossing fibers.
Yes. What's vital to remember is that fibers originating from the nasal half of each retina, the part of your vision towards your nose, cross the median plane right here to enter the optic tract of the opposite side. This crossing is absolutely fundamental to how our brain processes visual information from both eyes into a single image.
And the tuber cinereum, what's that?
This is a convex mass of gray matter clearly visible from the inferior surface. It's continuous inferiorly with the infundibulum.
The stalk.
The stalk, exactly. The infundibulum is hollow and becomes continuous with the posterior lobe of the hypophysis cerebri, or pituitary gland. The median eminence is a raised part of the tuber cinereum where the infundibulum attaches. Together, the median eminence, infundibulum, and posterior lobe, or pars nervosa, of the hypophysis form what's known as the neurohypophysis.
A key link between brain and hormones.
A critical link, yes, between the nervous and endocrine systems.
Finally, the mammillary bodies, what are they?
These are two small hemispherical bodies situated side by side just behind the tuber cinereum. They each contain a central core of gray matter encased by a capsule of myelinated nerve fibers.
Involved in memory, right?
Strongly implicated in memory circuits, yes. Posterior to them lies the posterior perforated substance, an area of the brain punctured by small apertures that transmit the central branches of the posterior cerebral arteries, supplying blood to crucial deep areas.
So, if the hypothalamus is so profoundly important for so many body functions, homeostasis, hormones, drives, what happens when it's diseased?
Yeah, given its widespread influence, lesions of the hypothalamus can lead to a really diverse range of conditions. They might result from infections, trauma, vascular disorders like stroke, or even tumors.
Like?
Things like craniopharyngiomas, chromophobe adenomas of the pituitary pressing upwards, or pineal tumors pressing downwards.
Right.
Common abnormalities include things like genital hypoplasia or atrophy, diabetes, insipidus problems with water balance, obesity, sleep disturbances, irregular fevers, pyrexia, and even severe emaciation. It's a wide spectrum.
And they can happen together?
Sometimes, yes. These disorders can occur together, such as in the adiposogenital dystrophy syndrome. This brings to mind that 12-year-old boy in our clinical problems.
The one who was overweight and underdeveloped.
Exactly. Excessively overweight and lacked external genitalia development. A clear case where disease of the diencephalon, particularly the hypothalamus, could indeed account for his condition. It really highlights how quickly a problem in this tiny area can throw the whole body completely out of balance.
It really underscores its central regulatory role. Okay, let's shift our focus now to the central cavity of the diencephalon itself. The third ventricle.
Right, the third ventricle. It's derived from the forebrain vesicle during development, and it presents as a narrow, slit-like cleft situated precisely between the two thalami.
The space between the two halves of the thalamus?
Exactly. It acts as a critical conduit, communicating anteriorly with the lateral ventricles, those large fluid spaces within the cerebral hemispheres, through the interventricular foramina, also known as the foramina of Monro.
All right.
Posteriorly, it connects with the fourth ventricle, located lower in the brainstem via the cerebral aqueduct. It's fully lined with ependema and possesses clearly defined walls that we can explore.
Can you walk us through those walls? Give us a sense of their boundaries and key features.
Certainly. The anterior wall is formed by a thin sheet of gray matter called the lamina terminalis. Across this runs the anterior commissure, that round bundle of nerve fibers connecting the right and left temporal lobes.
Right.
The posterior wall is defined by the opening into the cerebral aqueduct. Just superior to this opening is the small posterior commissure. Even further superior, you'll find the pineal recess, projecting into the stalk of the pineal body, and above that, the small habenular commissure.
Lots of commissures crossing nearby. And what about the lateral and superior walls?
The lateral wall is formed by the medial surface of the thalamus superiorly and the hypothalamus inferiorly,
Okay.
separated by that hypothalamic sulcus we mentioned. The stria medullaris thalami limits the lateral wall superiorly. And interestingly, the lateral walls are often joined by the interthalamic connection, that bridge of gray matter.
If it's present.
If it's present, yes. The superior wall, or roof, is a layer of ependyma that's continuous with the lining of the entire ventricular system. Superior to this ependymal layer is that two-layered fold of pia mater, the delicate brain covering, called the talochoroidea of the third ventricle.
Right.
From this talochoroidea, the vascular choroid plexuses of the third ventricle, our CSF factories, project downwards from the midline into the cavity. Also, the internal cerebral veins run within this talochoroidea, crucial for draining blood away. Superiorly, the roof is related to the fornix and the massive corpus callosum.
And what makes up the floor of the central ventricle?
The inferior wall, or floor, is formed by a sequence of structures from front to back. The optic chiasma, the tuber cinereum, the infundibulum, which has its own funnel-shaped recess, and the mammillary bodies.
Okay.
The hypophysis, or pituitary gland, is actually attached directly to the infundibulum. Posterior to these structures lies the tegmentum of the cerebral peduncles, connecting downwards to the brainstem.
This structure, the third ventricle and its connections, also pops up in clinical practice quite a bit, right? Problems here often have significant consequences due to CSF flow.
Absolutely. The lateral ventricles, which are upstream and communicate directly with the third ventricle via the foramina of Monro, each contain about 7 to 10 milliliters of cerebrospinal fluid.
Not a huge amount.
Not huge, but critical. This fluid is normally produced in the choroid plexus of the lateral ventricles and then flows into the third ventricle through those interventricular foramina. So blockage of a foramen by, say, a cerebral tumor would lead to distension of the upstream ventricle.
A backup.
A backup, causing a type of hydrocephalus, a buildup of CSF pressure. Our source even notes that in the past, quite dangerous methods like pneumoencephalography or ventriculography were used to investigate ventricle size.
Injecting air or dye.
Exactly. Thankfully, these have now been replaced by much safer and more precise CT and MRI scans.
Good to know.
What's also fascinating here is that the choroid plexus itself, particularly in its posterior part, can calcify with age.
Like the pineal gland.
Similar calcification, yes. As we saw in one of our clinical cases, this can sometimes show up on radiographs and shouldn't be confused with the calcification of the pineal gland. It was precisely this type of calcification that a medical student noted in a patient's left lateral ventricle, which, combined with an enlarged ventricle, strongly pointed to a tumor compressing the interventricular foramen on that side. It's a subtle but important diagnostic clue for professionals paying close attention.
That's a perfect illustration of how knowing the detailed anatomy translates directly to clinical diagnosis. All right, let's shift our focus now to the largest and most complex part of the brain, the cerebral hemispheres themselves.
Right, the big players. The two cerebral hemispheres are separated by a deep midline sagittal fissure running front to back known as the longitudinal cerebral fissure.
Okay.
This fissure contains a sickle-shaped fold of dura mater, the falx cerebri, which helps partition the hemispheres, and also the anterior cerebral arteries run within it.
And deep inside.
Deep within this fissure, physically connecting the hemispheres across the midline, is the great commissure, the corpus callosum, that massive bridge of nerve fibers.
Right.
Another horizontal fold of dura mater, the tentorium cerebelli, separates the cerebral hemispheres above from the cerebellum below.
And their appearance, they're certainly not smooth, are they? All those folds and wrinkles?
No, not at all. They maximize the surface area of the cerebral cortex, the gray matter, where so much of our higher level processing happens. Each hemisphere's surface is extensively folded.
More surface area means more processing power.
Essentially, yes. More room for neurons. The folds are called gyri, and the grooves separating them are known as sulci, or fissures.
Okay.
For descriptive ease, and definitely for clinical utility, each hemisphere is divided into major lobes, conveniently named according to the cranial bones they lie beneath: the frontal, parietal, temporal, and occipital lobes.
And boundaries.
Their boundaries are defined by key sulci, like the central, parieto-occipital, lateral, and calcarine sulci. These grooves are the landmarks.
Let's go through the main sulci then, as they delineate these important functional areas. What about the central sulcus? Why is it so important to identify?
The central sulcus is of paramount importance. It serves as the dividing line for primary motor and sensory functions on the lateral surface.
Motor in front, sensory behind.
Exactly. The gyrus immediately anterior to it, the precentral gyrus, contains the motor cells that initiate movements on the opposite side of the body. Posterior to it lies the postcentral gyrus, which is the general sensory cortex, receiving sensory information from the opposite side of the body.
Okay.
It indents the superior medial border of the hemisphere about 1 centimeter behind the midpoint and runs downward and forward across the lateral aspect of the hemisphere. Its lower end is typically separated from the posterior ramus of the lateral sulcus by a narrow bridge of cortex.
And it's unique how?
It's unique as the only sulcus of any significant length on this surface that both indents the superomedial border and lies between two parallel gyri, the pre- and postcentral gyri. So if you were having difficulty finding it, those landmarks are key. It's a crucial anatomical and functional divider.
Good tip.
And while the sulci and gyri are very similar on both sides, they do exhibit individual variations from person to person. Brains aren't identical photocopies.
Makes sense. And what about the lateral sulcus, often called the Sylvian fissure?
The lateral sulcus, yes. It's a deep cleft found mainly on the inferior and lateral surfaces of the hemisphere. It starts as a short stem that then divides into 3 distinct rami: the anterior horizontal ramus, the anterior ascending ramus, and it continues as the longer posterior ramus.
And deep inside it.
Deep at the very bottom of this sulcus lies a hidden area of cortex called the insula. You can't see it from the surface unless you gently separate the lips of the sulcus. It's a critical, tucked-away area involved in things like emotion, self-awareness, and taste.
Fascinating. And the parieto-occipital and calcarine sulci, they sound like they mark the back regions.
They do. The parieto-occipital sulcus begins on the superior medial margin of the hemisphere, about 5 centimeters anterior to the occipital pole, the very back tip.
Okay.
It then travels downward and anteriorly on the medial surface, the flat surface facing the other hemisphere, to meet the calcarine sulcus.
And the calcarine.
The calcarine sulcus itself is found on the medial surface of the hemisphere, specifically within the occipital lobe. It originates under the posterior end of the corpus callosum and arches upward and backward to reach the occipital pole, though in some brains it extends a short distance onto the lateral surface.
Okay.
It's joined at an acute angle by the parieto-occipital sulcus about halfway along its length. And most importantly, the primary visual cortex, the area responsible for processing basic visual information, is located right along the banks of the calcarine sulcus.
So with these sulci as our guides, what does this all mean for the specific cerebral hemisphere lobes themselves? Let's break them down by lobe. Start with the frontal lobe.
Okay. The frontal lobe occupies the area anterior to the central sulcus and superior to the lateral sulcus. It's the biggest lobe.
Right.
Its superlateral surface, the side you'd see from the outside, is divided by 3 sulci: the precentral, superior frontal, and inferior frontal sulci. These divide it into 4 gyri: the precentral gyrus, motor cortex, superior frontal, middle frontal, and inferior frontal gyri.
Oh.
The inferior frontal gyrus is actually invaded by the anterior and ascending rami of the lateral sulcus, creating distinct parts often associated with language production, like Broca's area in the dominant hemisphere.
Right.
For instance, if a neurosurgeon were removing a glioma, a type of tumor, from the right middle frontal gyrus, they would be precisely working on the lateral surface of the frontal lobe, bounded superiorly by the superior frontal sulcus and inferiorly by the inferior frontal sulcus, all under the frontal bone. This is the lobe associated with planning, decision-making, working memory, personality, and higher executive functions.
Got it. And the parietal lobe, behind the frontal.
Exactly. This lobe is located posterior to the central sulcus and superior to the lateral sulcus, extending backward as far as the parieto-occipital sulcus.
Okay.
Its lateral surface is divided by 2 main sulci: the postcentral sulcus, just behind the sensory cortex, and the intraparietal sulcus into 3 gyria or regions: the postcentral gyrus, sensory cortex, the superior parietal lobule, and the inferior parietal lobule.
And its job?
It's primarily involved in processing sensory information: touch, temperature, pain, pressure, spatial awareness, navigation, and integrating sensory input.
Okay. The temporal lobe, below the lateral sulcus.
Correct. It occupies the area inferior to the lateral sulcus. Its lateral surface is divided into 3 gyri: the superior, middle, and inferior temporal gyri by 2 sulci: the superior and middle temporal sulci.
Okay.
The inferior temporal gyrus continues onto the inferior surface of the hemisphere. And it's worth noting, as we touched on, that a cerebral abscess causing symptoms that started with an earache, like in one of our clinical problems, would most likely be located in the temporal lobe due to the close proximity of the ear structures to this lobe.
Makes sense.
And function.
This lobe is crucial for auditory processing, understanding language. Wernicke's area is typically here. Memory formation, thanks to the hippocampus tucked inside, and object recognition.
And finally, the occipital lobe, at the very back.
That's the one. This is the smallest distinct lobe area located behind the parieto-occipital sulcus. And as we noted, it's primarily dedicated to processing visual information. Everything you see gets processed back there first. What about the medial and inferior surfaces? You mentioned the lobes aren't as clearly defined by those deep sulci there. Are there other unique, important areas to recognize on those surfaces?
Yes, absolutely. The boundaries are less distinct, but several important areas must be recognized. The corpus callosum, that huge commissure, is a striking feature on the medial view.
Right.
The cingulate gyrus begins beneath the anterior end of the corpus callosum and curves upward and backward, continuing above it to its posterior end. It's separated from the corpus callosum by the callosal sulcus and from the superior frontal gyrus above it by the cingulate sulcus. It's a key part of the limbic system.
Emotion and motivation.
Emotion, motivation, learning, memory, yes. Then there's the paracentral lobule. This is the cortical area on the medial surface surrounding the indentation made by the central sulcus as it comes over the top edge. Its anterior part is a continuation of the precentral motor gyrus, and its posterior part is a continuation of the postcentral sensory gyrus.
So it controls motor and sensory for the leg and foot area.
Primarily, yes. Motor and sensory functions for the contralateral leg and foot are represented here.
Any other unique areas on those medial or inferior surfaces that professionals really focus on?
Yes, definitely. The precuneus is an area on the medial parietal lobe, bounded anteriorly by the upturned posterior end of the cingulate sulcus and posteriorly by the parieto-occipital sulcus. It's involved in complex functions like visual spatial imagery and self-awareness.
Okay.
The cuneus is a triangular cortical area in the occipital lobe, bounded above by the parieto-occipital sulcus, inferiorly by the calcarine sulcus, and posteriorly by the superior medial margin. It's part of the visual cortex processing information from the lower visual field.
Right.
On the inferior surface, you'll find the collateral sulcus running anteriorly below the calcarine sulcus. Between them is the lingual gyrus. Anterior to the lingual gyrus is the parahippocampal gyrus, which terminates anteriorly as the hook-like uncus.
Part of the memory system again?
A key part of the limbic system involved in memory encoding and retrieval, yes. The medial occipitotemporal gyrus extends from the occipital to the temporal pole, bounded medially by the collateral and rhinal sulci, and laterally by the occipitotemporal sulcus. The occipitotemporal gyrus lies lateral to its sulcus and is continuous with the inferior temporal gyrus. These are involved in visual processing, like recognizing faces and objects.
Wow.
Finally, on the inferior surface of the frontal lobe, you have the olfactory bulb and tractar structures for smell overlying the olfactory sulcus. Medial to that is the gyrus rectus, and lateral are the orbital gyri, involved in decision-making and emotion regulation. It's an incredibly packed and interconnected landscape.
It truly is. So we connect this back to the bigger picture. Why does this incredibly detailed anatomical division into lobes and gyri matter so much clinically? What's the so what for a physician trying to diagnose a patient?
It matters immensely. The cerebral cortex is composed of gray matter, and here's a key insight. Only about a third of it actually lies on the exposed, visible convexity of the gyri.
Most of it's hidden.
The remaining two-thirds are hidden down in the walls of the sulci. Now, different cortical areas, corresponding roughly to these anatomical divisions, have distinct functions. So this precise anatomical division by lobes and gyri allows physicians to accurately localize a loss of function or pinpoint a brain lesion with remarkable precision.
It's like having a functional map overlaid on the anatomy.
Exactly. For example, focal lesions, meaning a localized damage of the precentral gyrus, will predictably produce contralateral hemiparesis, weakness on the opposite side. Lesions of the postcentral gyrus result in contralateral hemisensory loss. More widespread frontal lobe lesions might cause broader symptoms indicating a loss of attention span or significant changes in social behavior. And widespread degeneration of the cerebral cortex, as in diseases like Alzheimer's, gives rise to the global symptoms of dementia. It's a fundamental roadmap for neurological diagnosis and understanding.
That's incredibly powerful, like a precise GPS for the brain. Okay, beyond the surface cortex, what's inside these cerebral hemispheres? What deep structures are critical for us to understand to get that professional level grasp?
Right, the interior. It's indeed quite complex and equally vital. Covered by the cerebral cortex, the hemispheres contain the fluid-filled lateral ventricles, important masses of gray matter known as the basal nuclei, and a vast, intricate network of nerve fibers that constitute the white matter. All of this is supported by neuroglia, the brain's essential supportive cells.
Let's start with the lateral ventricles. What defines these cavities? We know they connect to the third ventricle.
Each cerebral hemisphere contains one of the two lateral ventricles. These are roughly C-shaped cavities, lined with that ependyma lining and filled with cerebrospinal fluid, the CSF.
Okay.
Each can be descriptively divided into a body, which occupies the parietal lobe and from which 3 horns extend. An anterior horn reaching into the frontal lobe, a posterior horn into the occipital lobe, and an inferior horn curving down into the temporal lobe.
Following the curve of the hemisphere.
Pretty much, yeah. And crucially, as you said, each lateral ventricle communicates with the third ventricle through the interventricular foramen, or foramen of Monro. This opening lies in the anterior part of the medial wall of the lateral ventricle, bounded anteriorly by the anterior column of the fornix and posteriorly by the anterior end of the thalamus.
Got it. Next, the basal nuclei. You mentioned them earlier. What are they and what's their overall purpose? Sometimes called basal ganglia.
Yes, the terms basal nuclei and basal ganglia are often used interchangeably, though nuclei is technically more accurate as ganglia usually refers to collections of nerve cells outside the central nervous system. But functionally, they refer to a collection of gray matter masses situated deep within each cerebral hemisphere.
Okay.
They include the corpus striatum, the amygdaloid nucleus, and the claustrum.
Tell us more about the corpus striatum. It sounds like a major player, especially in movement.
It absolutely is. The corpus striatum is located lateral to the thalamus and is almost completely divided by a dense band of nerve fibers, the internal capsule, into 2 main parts, the caudate nucleus and the lentiform nucleus.
Okay, break those down.
Sure. The caudate nucleus is a large C-shaped mass of gray matter closely related to the lateral ventricle following its curve. It lies lateral to the thalamus, and its lateral surface is directly related to the internal capsule, which separates it from the lentiform nucleus.
And the lentiform.
The lentiform nucleus is a wedge-shaped or lens-shaped mass of gray matter buried deep in the white matter. Its broad, convex base points laterally, and its blade points medially. Medially, it's related to the internal capsule, which separates it from both the caudate nucleus and the thalamus. Laterally, it's separated from a thin sheet of gray matter called the claustrum by an even thinner sheet of white matter called the external capsule. The claustrum, in turn, separates the external capsule from the subcortical white matter of the insula, and at its anterior end, inferiorly, the lentiform nucleus is continuous with the caudate nucleus they touch there.
So given all those connections, particularly with motor areas in the thalamus, what's the core function of the corpus striatum? How does it influence movement?
Its primary function is profoundly concerned with muscular movement. But here's the key nuance. It accomplishes this mainly by controlling the cerebral cortex itself, rather than through direct descending pathways to the brainstem and spinal cord like the main motor cortex does.
So it's more of a modulator or a planner.
A sophisticated modulator, exactly. It helps select and sequence movements, inhibit unwanted movements, and learn motor skills. It receives incoming or afferent fibers from various areas of the cerebral cortex, the thalamus, subthalamus, and brainstem. Then it sends outgoing or efferent fibers back to these same areas, forming complex feedback loops that refine motor commands.
What about the other basal nuclei you listed? The amygdaloid nucleus.
The amygdaloid nucleus, or amygdala, is located in the temporal lobe, close to the uncus. It's considered a very important part of the limbic system, deeply involved in processing emotions, particularly fear, learning emotional responses, and linking emotions to memories.
Not primarily movement, then?
Not primarily movement, more emotion and motivation, though it interacts with motor systems.
And the claustrum. You mentioned it was thin and lateral to the lentiform nucleus. What do we know about its function?
The claustrum is that thin, irregular sheet of gray matter we mentioned, separated from the lateral surface of the lentiform nucleus by the external capsule. Lateral to the claustrum is the subcortical white matter of the insula. Its specific function, however, remains one of the fascinating ongoing mysteries of the brain. Some theories suggest it plays a role in consciousness or integrating information across different modalities, but it's currently largely unknown.
That makes me wonder, If these basal nuclei are so intricately connected, especially the corpus striatum, and involved in movement, what happens clinically if they are damaged?
Yeah, due to their very close relationship with the internal capsule, that dense highway of fibers running right through or beside them, tumors or lesions like strokes affecting the caudate or lentiform nuclei can cause severe motor or sensory symptoms on the opposite side of the body.
Okay.
For instance, tumors pressing on the anterior two-thirds of the posterior limb of the internal capsule, where motor fibers run, will lead to progressive spastic hemiplegia paralysis with muscle stiffness on the contralateral side. Conversely, more posteriorly situated tumors might primarily affect the sensory fibers in the capsule, producing impairment of sensation on the opposite side. This high concentration of crucial fibers means even small lesions in or near the basal nuclei or internal capsule can have profound effects. Diseases like Parkinson's and Huntington's also directly involve degeneration within the basal nuclei.
That really drives home the importance of location. Okay, let's move on to the white matter itself, the brain's vast network of connections. How is this intricate wiring system organized?
Right, the white matter. It's primarily composed of myelinated nerve fibers, axons, wrapped in a fatty insulation of different diameters, all supported by neuroglia. These nerve fibers are broadly classified into three main groups based on their connections and the directions they travel: commissural fibers, association fibers, and projecting fibers.
Let's start with commissural fibers. What do they do? Connect the hemispheres.
Exactly. Commissural fibers are the cross-hemisphere communicators. They connect corresponding regions of the two cerebral hemispheres, allowing them to work together.
And the biggest one is?
The corpus callosum. By far the largest commissure of the brain, a truly massive structure connecting the two cerebral hemispheres across the longitudinal fissure. Descriptively, it's divided into the rostrum, the beak-like front part, the genu, the curved anterior end or knee, the body, the main trunk, and the splenium, the thickened posterior portion. Traced laterally, the fibers of the genu curve forward into the frontal lobes, forming what we call the forceps minor. The fibers of the body extend laterally as the radiation of the corpus callosum, intersecting with association and projection fibers as they fan out to the cortex. Some of these fibers form the roof and lateral wall of the posterior horn of the lateral ventricle and the lateral wall of the inferior horn. These are referred to as the tapetum.
Okay.
The fibers in the splenium at the back arch backward into the occipital lobe, forming the forceps major. It's a huge interconnecting structure.
Are there other commissures?
Yes, several smaller ones. The anterior commissure is a much smaller bundle of nerve fibers that crosses the midline in the lamina terminalis, near the front of the third ventricle. Laterally, a smaller anterior bundle curves forward towards the anterior perforated substance and the olfactory tract. A larger bundle curves posteriorly on each side, subtly grooving the inferior surface of the lentiform nucleus as it reaches the temporal lobes, connecting parts of the temporal lobes and olfactory structures. The posterior commissure is another bundle of nerve fibers that crosses the midline immediately above the opening of the cerebral aqueduct into the third ventricle, related to the inferior part of the pineal gland stalk. While the precise destinations of many of its fibers are still unknown, fibers from the protectal nuclei, which are involved in the pupillary light reflex, your pupils constricting in bright light, are believed to cross here on their way to the parasympathetic part of the oculomotor nuclei.
And the fornix, you mentioned that earlier, connecting hippocampus to mammillary bodies. Does it have a commissural part?
It does, yes. The fornix itself is primarily an efferent or outgoing system of the hippocampus, passing to the mammillary bodies of the hypothalamus. Its fibers first form the alveus, a thin layer of white matter covering the ventricular surface of the hippocampus, then converge to form the fimbria. The fimbriae from the two sides thicken and arch forward above the thalamus and below the corpus callosum to form the posterior columns of the fornix. These two columns then come together in the midline to form the body of the fornix.
And the crossing part.
Right before the body forms, there's the commissure of the fornix, consisting of transverse fibers that cross the midline from one column to another. This connects the hippocampal formations of the two sides.
Okay, one more.
The habenular commissure, a small bundle of nerve fibers that crosses the midline in the superior part of the pineal stalk's root. It's associated with the habenular nuclei on either side. These nuclei receive signals from the amygdaloid nuclei and hippocampus via the sturius medullaris thalami. Some of these fibers then cross the midline to the contralateral nucleus through this commissure. Its function in humans isn't fully clear.
This makes me wonder again, what happens if these critical commissures, especially the massive corpus callosum, are damaged or even absent from birth? You mentioned the split brain idea.
Yeah, that's where it gets truly fascinating, clinically and experimentally. The corpus callosum is absolutely essential for integrating complex information between the hemispheres, things like learned discrimination, combining sensory experience from both sides, and consolidating certain types of memory.
But what if it's missing?
What's remarkable here is that if it simply fails to develop a condition called agenesis of the corpus callosum, patients often show surprisingly few definite overt signs or symptoms in daily life.
How is that possible?
It's as if the brain adapts, possibly by strengthening other, smaller commissural pathways like the anterior commissure, or perhaps developing different processing strategies within each hemisphere. The brain's plasticity is incredible.
But if it's damaged later?
If it's destroyed by disease, like a stroke affecting it or surgically section, which was historically done for severe intractable epilepsy to stop seizure spreading, then each hemisphere becomes functionally isolated. The patient responds under specific testing conditions as if they have two separate brains.
So they seem normal day to day.
Often, yes. Their general intelligence and behavior may appear quite normal because both hemispheres have learned to respond to different situations over the years through shared experience. But the lack of interhemispheric communication becomes strikingly apparent when tested specifically.
Like the pencil example.
Exactly like the pencil example. Place a pencil in their right hand with eyes closed. The sensory info goes to the left hemisphere, which controls speech, and they can name it.
Okay.
Place the same pencil in their left hand, the tactile information goes to the right postcentral gyrus. But this information cannot travel through the severed corpus callosum to the speech area in the left hemisphere. So the patient will be completely unable to verbally describe the object, even though their right brain knows what it is through touch. They might be able to point to it with their left hand, but can't name it. It's a profound demonstration of brain lateralization and the necessity of interhemispheric connection for unified conscious experience.
Wow, that's truly mind-boggling to imagine living with. It really highlights the incredible specialization, but also the necessary collaboration within our brains. Okay, let's move on to the association fibers. What's their role? Connecting within one hemisphere.
Exactly. Association fibers connect various cortical regions within the same hemisphere. Think of them as the internal communication network for each side, linking different functional areas together. They are divided into two groups, short and long. The short association fibers lie immediately beneath the cortex and connect adjacent gyri, often running transversely, perpendicular to the long axis of the sulci. They link neighboring processing areas.
And the long ones.
The long association fibers are collected into several major name bundles that travel longer distances. The uncinate fasciculus is a hook-shaped bundle connecting the frontal lobe, particularly areas involved in decision-making and emotion, with the anterior part of the temporal lobe. The cingulum is a long, curved fasciculus found within the white matter of the cingulate gyrus, running front to back. It connects the frontal and parietal lobes with parahippocampal and adjacent temporal cortical regions. It's a major pathway within the limbic system. The superior longitudinal fasciculus, SLF, is the largest association bundle, arching across the lateral aspect of the hemisphere. It connects the frontal lobe to the parietal, occipital, and temporal lobes. It's actually thought to be composed of several subpathways crucial for language, attention, and spatial processing. The inferior longitudinal fasciculus, ILF, runs anteriorly from the occipital lobe, passing lateral to the optic radiation, and is distributed to the temporal lobe. It's thought to be vital for visual recognition, linking what you see with your knowledge about it. The fronto-occipital fasciculus connects the frontal lobe to the occipital and temporal lobes. It is situated deep within the cerebral hemisphere, related to the lateral border of the caudate nucleus.
So these allow different parts of one hemisphere to talk to each other for complex tasks.
Precisely. Language, reading, decision-making, recognizing objects, they all require coordination between different specialized cortical areas within a hemisphere enabled by these association fibers.
And finally, projection fibers. What's their function in this complex network, connecting cortex to lower structures?
That's right. Projection fibers are the vital afferent incoming sensory and efferent outgoing motor nerve fibers passing to and from the brainstem and spinal cord, connecting them to the entire cerebral cortex. They carry signals up from the body and senses and commands down from the cortex.
And they form the internal capsule.
At the upper part of the brainstem, these ascending and descending fibers converge to form that remarkably compact band known as the internal capsule, squeezed between the thalamus and basal nuclei. It's flanked medially by the caudate nucleus and the thalamus, and laterally by the lentiform nucleus. Because of the wedge shape of the lentiform nucleus, the internal capsule is bent, forming an anterior limb and a posterior limb, which are continuous at the genu or knee.
And then they fan out?
Exactly. Once these nerve fibers emerge superiorly from between these deep gray matter masses, they radiate in all directions to the cerebral cortex. These widely fanning fibers are known as the corona radiata, meaning radiating crown.
A beautiful image.
It is. Most projection fibers lie medial to the association fibers, but crucially intersect the commissural fibers of the corpus callosum and the anterior commissure. The internal capsule and corona radiata represent a true crossroads of all major fiber types connecting cortex to the rest of the nervous system.
So the internal capsule really is the brain's main information superhighway in and out of the cortex. What are some of the most critical fiber tracks within it, and why is that concentration so important for understanding function and dysfunction?
Okay, key tracks. The bend and the anterior part of the posterior limb contain the corticobulbar fibers, going to cranial nerve nuclei in the brainstem, and corticospinal fibers going down to the spinal cord. These are absolutely crucial for conscious motor control of the face and body.
Right.
Thalamocortical fibers, which relay general sensation from the thalamus up to the sensory cortex, radiate from the posterior limb towards the parietal lobe. And the posterior part of the posterior limb gives rise to the optic radiation, which carries visual information from the thalamus back towards the calcarine sulcus in the occipital lobe. Auditory radiations also pass through here towards the temporal lobe.
So motor, sensory, visual, auditory pathways all squeezed together.
All tightly packed in there. Inferiorly, the internal capsule is continuous with the crus cerebri of the midbrain, carrying fibers down, and superiorly, it fans out into that corona radiata. It's a critical bottleneck.
That makes me wonder again, you mentioned earlier that the internal capsule is often the site of pathological lesions, especially strokes. Why is that specific area so vulnerable and the effects so devastating?
Yes, the internal capsule is indeed frequently involved in vascular disorders of the brain, particularly strokes. The most common cause of arterial hemorrhage there is often related to atheromatous degeneration, hardening, and narrowing of small arteries in a patient with high blood pressure. Tiny arteries supplying this deep area are particularly susceptible.
Okay.
Because of the extremely high concentration of so many important nerve fibers within this relatively small space, even a small hemorrhage or blockage can cause widespread and devastating effects on the contralateral side of the body.
More damage from a smaller lesion.
Exactly. Not only is the immediate neural tissue destroyed by the blood or lack of oxygen, but neighboring nerve fibers within the capsule may also be severely compressed or become edematous, meaning they swell, further disrupting function. This is precisely what happened to our 70-year-old hypertensive patient in the clinical section. A small hemorrhage, starting perhaps in the left thalamus, extended laterally into the posterior limb of the left internal capsule.
And the result?
Transient right hemiparesis weakness on his right side and numbness. The likely cause was a ruptured, diseased small artery, like a thalamic or lenticulostriate artery, directly highlighting the severe consequences of uncontrolled hypertension on brain health via these vulnerable, deep structures.
It truly drives home the fragility of such a complex, concentrated system. Okay, finally, what about the other important supporting structures we mentioned briefly earlier? The septum pellucidum and the telechoroidea.
Right. Two more structures worth noting. The septum pellucidum is a thin, vertical sheet of nervous tissue, a combination of white and gray matter covered by ependema that stretches between the fornix below and the corpus callosum above.
A partition.
Essentially, yes. It occupies the interval between the body of the corpus callosum and its rostrum interiorly. It's usually a double membrane with a closed, slit-like potential cavity between the two layers, and it forms a partition between the anterior horns of the two lateral ventricles. It helps separate those fluid spaces.
And the telechoroidea. We mentioned it regarding the ventricle's roof and CSF production.
Exactly. The telechoroidea is that specialized, two-layered fold of pia mater, the innermost brain covering. It forms the roof of the third ventricle and also covers the upper surfaces of the two thalami inferiorly.
Okay.
Its anterior end is situated at the interventricular foramina. Its lateral edges are irregular and folded, projecting laterally into the body of the lateral ventricles. Here, they are covered by ependema and form the bulk of the choroid plexuses of the lateral ventricle major sites of CSF production.
And extends.
Posteriorly, these edges continue into the inferior horn of the lateral ventricle, forming the choroid plexus there too. On either side of the midline, the talachoroidea also projects down through the roof of the third ventricle to form the smaller choroid plexus of the third ventricle.
Where does its blood supply come from?
Its rich blood supply is derived from the choroidal branches of the internal carotid and basilar arteries. Venous blood drains into the internal cerebral veins, which run within the talachoroidea itself. These veins then unite to form the great cerebral vein of Galen, which ultimately joins the inferior sagittal sinus to drain blood away from the deep brain structures. It's the vascular membrane that underlies and supports much of the CSF production system.
We've touched on several clinical conditions throughout this deep dive: the cyst, the stroke, the hemoblismus. Let's bring some of this together by looking at Alzheimer's disease, which profoundly affects the cerebral cortex and deeper structures we discussed.
Yes, Alzheimer's disease provides a sobering example of how degeneration in these systems manifests. It's a progressive degenerative disease of the brain, typically occurring in middle to late life, though unfortunately early onset forms are also recognized.
And the cause?
Its exact cause remains frustratingly unknown, but strong evidence suggests a complex interplay of genetic predisposition and environmental factors. Specific mutations have been found in genes like APP, amyloid precursor protein, presenilin-1, and presenilin-2, especially in early-onset familial cases.
What are the typical signs?
Early signs often involve insidious memory loss, particularly for recent events. This progresses to a subtle personality disintegration, leading eventually to complete disorientation, marked deterioration in speech and language, and restlessness or agitation. In the late stages, patients may become mute, incontinent, completely bedridden, and often succumb to other complications like infections.
So what's actually happening in the brain at a microscopic level that leads to such widespread and devastating symptoms?
Microscopically, characteristic changes eventually occur throughout the cerebral cortex, but they selectively involve certain regions particularly heavily early on. Critically, this includes the hippocampus, the entorhinal cortex, a gateway to the hippocampus, and their associated cortical areas in the temporal and parietal lobes regions, absolutely vital for memory formation and retrieval.
And the hallmarks are plaques and tangles, right?
Exactly. The two main pathological hallmarks are: 1. Numerous senile plaques, which are extracellular deposits. They result from the accumulation of several proteins, most notably toxic forms of beta-amyloid peptide, surrounded by degenerating nerve endings, neurates. 2. Neurofibrillary tangles, which are intracellular accumulations. These are composed of hyperphosphorylated tau protein, a protein normally involved in stabilizing microtubules within neurons. In Alzheimer's, tau becomes abnormal and aggregates into tangles, disrupting neuronal transport and function.
And neurotransmitters are affected too.
Yes, there's also a significant loss of choline acetyltransferase, the enzyme responsible for synthesizing acetylcholine, a crucial neurotransmitter for memory and cognition in affected cortical areas. This loss is thought to be due, at least in part, to the degeneration of ascending projection fibers from deep nuclei, like the nucleus basalis of Meinert, rather than just the loss of cortical cells themselves. As all these cellular changes accumulate, the affected neurons ultimately die, leading to the characteristic brain atrophy or shrinkage seen in later stages.
How is it currently diagnosed? Is there a definitive test?
Currently, there's no single definitive clinical test for Alzheimer's while someone is alive. A truly definitive diagnosis often still requires post-mortem examination of brain tissue. In clinical practice, diagnosis relies on a careful medical history from the patient and family, serial neurological and psychiatric examinations to track cognitive decline and exclude other potential causes of dementia, like vascular dementia, Lewy body dementia, etc.
Are there any helpful tests?
Yes, supportive tests are becoming increasingly important. Biomarkers, such as measuring levels of amyloid peptides or tau proteins in cerebrospinal fluid, obtained via spinal tap or potentially through advanced blood tests, are showing promise. Imaging also plays a crucial role. CT scans or MRIs can show characteristic patterns of brain atrophy, particularly in the medial temporal lobe, hippocampus area in early stages. In advanced cases, they reveal more widespread thinning of the cerebral cortex and enlarged ventricles as brain tissue is lost.
What about functional scans?
Positron emission tomography, PET scans, are also very useful. FDG-PT can show patterns of diminished cortical metabolism, particularly in temporoparietal regions. Amyloid PT and typet scans can directly visualize the plaque and tangle pathology in the living brain, which is a major advance for diagnosis and tracking disease progression, especially in research settings.
And what about treatment options currently?
At present, treatments primarily focus on managing symptoms and trying to slow the rate of decline, though they don't stop or reverse the underlying disease process. Cholinesterase inhibitors like donepezil, ribostigmine, and galantamine are commonly used. They work by increasing the levels of acetylcholine in the brain, compensating somewhat for the loss of acetylcholine-producing neurons.
Do they help significantly?
They can offer modest symptomatic benefits for cognition, function, and behavior for some patients for a period of time. Another medication, memantine, works on a different neurotransmitter system, glutamate, and is often used for moderate to severe stages. More recently, new antibody-based therapies targeting amyloid plaques have received conditional approval in some regions, but their clinical benefit versus risks and costs are still subjects of significant ongoing research and debate. Lifestyle factors, managing cardiovascular health, and supportive care remain crucial.
We've truly gone deep today. We've unpacked the cerebrum, the diencephalon, its intricate components like the thalamus and hypothalamus, navigated the complex network of white matter tracts, and even explored the devastating impact of conditions like Alzheimer's that target these very structures. You should now possess a much more detailed, almost professional-level understanding of this incredible organ.
Absolutely. And the striking thing throughout this detailed exploration is the sheer elegance and, frankly, the mind-boggling interconnectedness of all these structures. From a tiny mobile cyst impacting consciousness and movement, to a hidden network of fibers allowing us to perceive and react to the world, every single part plays a critical, often surprising role. Understanding their precise anatomical relationships and their functional interplay is absolutely key to comprehending both the brain's vast capabilities and its equally profound vulnerabilities.
So what does this all mean for you, listening right now? It means you now have a far deeper appreciation for the incredibly complex machine within your own head. How it's built, piece by intricate piece, how it functions, and what happens when parts of that system are compromised. This isn't just abstract theory, it's the fundamental basis for understanding our thoughts, feelings, actions, and our very selves.
And this detailed knowledge raises an important final question for you to ponder. Given the brain's truly remarkable capacity for adaptation and plasticity, as we saw hinted at in cases of corpus callosum agenesis where other pathways seemingly compensate, what might this imply about the brain's potential to compensate for other types of damage acquired later in life, or even its inherent ability to learn entirely new functions and fundamentally rewire itself in response to new experiences, challenges, or rehabilitation efforts? It speaks to the enduring potential within this complex organ, something to definitely think about as you continue your own deep dive into knowledge.
Absolutely. A fantastic point to end on. Thank you for joining us on this deep dive into the cerebrum. Until next time, keep digging to the details.